Now we're going to talk about a particular kind of interview, often embodied or, a part of a larger interview, the mental status exam. One of the most important ways that we evaluate a person's current functioning is clinical observation, and the mental status exam is a really useful way of organizing our observational data. The mental status exam is kind of the psychological equivalent of a physical exam, really, but it describes the mental state and behaviors of the person being seen. And it includes, as I said, it's observational. It includes objective observations of the clinician and also subjective descriptions that the patient gives. The mental status exam provides information for diagnosis and assessment and response to treatment. It's kind of a snapshot at a particular point in time. And the reason you do it is really to increase the reliability of the data that you'll be using to make subsequent diagnoses and case formulations. As I think I said, most assessment reports, if an interview was part of assessment, include a brief overview of mental status in the report, and I'll give you an idea of what that looks like in a little bit. Routinely, it's given to elderly people or other patients who are being evaluated for dementia, given to patients who come into acute psychiatric ER, I guess is what I'm trying to say. And it includes all of these things: descriptions of appearance, behavior, speech, mood, affect, thought process, thought content, cognition, insight, and judgment, all defined in a particular way, which I am now going to talk about. The mental status exam also includes the interviewer's observation about the client's attitude, the client's cooperativeness, as well as sometimes their answers to specific questions that are collected throughout the course of the interview and then all put in the mental status section. And the results of the mental status may suggest specific areas for further testing or types of required tests. For example, if cognitive deficits show up in your mental status exam, you may want to include some tests of cognition, memory, judgment, and so on in your battery that you're going to be using. It's also important to collect information about the person's cultural, social, educational background, because you always want to be sure that you understand what's normal for the client. There may be different cultural norms. There may be just different quirks that the person has always had that don't indicate a problem. So you may talk about pressured speech and think of manic behavior unless you know that this particular person who's talking so rapidly always speaks fast. Okay, let's start by describing the sections that will go into your mental status report. First of all, appearance is a really broad one, and really it's important. It's really a very important indicator of current functioning, how someone behaves, how they appear. So you give a concise summary of the client's physical presentation to really paint a clear portrait of them, their dress, their grooming, their facial expression, posture, eye contact, as well as any relevant, noteworthy aspects of appearance. And I can't think of an example right now, but maybe one will come to me. Behavior. This includes a lot of stuff. Here's some of the really important things. Eye contact. Is it good eye contact? Avoidant? Piercing? Level of motor activity. So psychomotor retardation, you might see in someone who's depressed, or hyperactivity. How coordinated are they? Their fine and gross motor functioning. This you might observe with gait and the way the person manipulates objects or writes during the testing or the interview. Behavior refers both to any kind of abnormal or repetitive behavior too, like constant leg jiggling, throat clearing, and also the person's relatedness toward you. So are they cooperative? Are they friendly? Guardedness, eye contact also is a clue to their relatedness toward you. And of course you want to factor in cultural factors here, or consider them. If you're talking about level of alertness, you can talk about a whole range of different degrees of alertness. So extending from alert to, say, drowsy. Their consciousness is a little bit clouded. Stupor, where they are simply not reacting at all to environmental stimuli. Delirium, they're bewildered or restless or disoriented. And I guess the end stage of alertness would be coma, but you likely wouldn't be interviewing them if they were in a coma. You want to make note of their degree of arousal. Say, are they really hypervigilant to environmental cues, the way you might see with someone who is in drug withdrawal or has PTSD? Are they hyper-aroused? They're very anxious. They're in a manic state. And do they have any mannerisms? Any tics? Any compulsions? Continuing to run fingers through the hair, for example, would be an example of a kind of a compulsive behavior that you might observe and make note of in your mental status exam. So, why do you want to know this? I've had people question in the past why you would spend time talking about someone's appearance. It sounds kind of trivial. But no, not really, because you can get important clues to the person's functional impairment. If you have a client who comes into your office for an interview and their hair is really disheveled, their shirt's only tucked in on one side, I guess I'm thinking of a he here, let's say his zipper is down, pretty significant, inappropriate appearance, and it can be a major clue that something is not going well for him at the moment. It might be something relatively benign. He has sick children at home, or something else that causes situational distress that's not real significant. Or his appearance can signify something more serious, like disorganized thinking or behavior that's associated with psychosis. So if whatever it signifies, it's important to note it, because ultimately whatever you learn from the assessment should explain why he came in so disheveled. Say you have a woman who comes in wearing inappropriately seductive clothing, really low cut, showing a lot of cleavage. It gives you some clinical information, clues as to some possibilities about her functioning. And if you also happen to know that she's being assessed as part of a custody evaluation for her children, you might come up with a couple of explanations for her what seems like really seductive attire. Maybe she's working really hard to be liked and seen favorably by the assessor. And this is one way that she thinks works, to be liked. particularly by a male assessor. And that may, on the one hand, relate to her desperation to get her kids back, or maybe she's, got some sort of histrionic or narcissistic kind of a presentation. So important things, whatever the reason for the behavior, you want to note it and incorporate it into the assessment, because the behavior is significant. The unusual behavior, deviant behavior, is significant clinical data that you want to be able to use and explain with the results of your assessment. And then we have speech and language. A person's language functioning critically affects your ability to adequately assess them in all domains of functioning. So if you notice that the client doesn't understand very well what you're saying, you're going to need to adjust the selection of tests for the battery to make sure that he'll be able to understand the test instructions. Or if a person's vocabulary is so limited that they can't make their point known, then a lot of the information that you get from them in the interview needs to be interpreted with this problem, this barrier in mind. You want to evaluate two aspects of language, receptive and expressive elements. So receptive language, as you know, refers to language comprehension. And you want to, again, note whether or not the person seems to understand all that you're saying, whether they require you to repeat things a lot. Expressive language refers to the individual's actual use of language to make his or her points known. So the level of vocabulary, the clarity of expression, the appropriateness of word use, and then aspects of speech, such as loud, soft, mute, how well they can articulate things, whether their speech is slurred, the volume, I guess I said that, all of those things you want to make note of, particularly anything that seems deviant. Is the speech very reduced, the spontaneous speech? We refer to that as impoverished speech, or poverty of speech, and it's diagnostic in some cases, or at least it's indicative of some diagnosis like schizophrenia, or someone who's very shy or is not very articulate. Is their speech very rapid, hard to interpret and understand? In that kind of a case, you're perhaps going to consider something like mania or a hypomanic state. Aphasia, that is, the person can't express themselves very well. Non-fluent aphasia, the speech is kind of slow and faltering. Fluent aphasia, it seems normal in terms of, rate and rhythm and quantity, but a lot of it is meaningless, or they're producing novel words. Now, an important distinction in the mental status exam is the difference between mood and affect, and I'll talk about them separately. With mood, we're referring to the current emotional state of the person as reported by the person. So you ask them how they're feeling. Affect, on the other hand, refers to the observed emotional state of the individual, what you infer by looking at their facial expression or their general body language. It's important to evaluate these things separately, and a very important aspect of both is whether or not both are, first of all, appropriate to the situation. They're appropriately happy when they should be happy, rather than crying when they're telling you about something that should be happy news. And appropriate to each other. Are mood and affect in sync? Does what they tell you they feel jibe with what they look like they feel? And that, whether the person reports a mood similar to the affect you observe is actually referred to as mood-affect congruence. And a lot of times affect is mood incongruent, and making a note of it is really important and may be important later in the assessment. So you've got a woman who reports feeling sad, but she doesn't stop laughing or smiling throughout the entire interview. So the fact that she doesn't seem depressed to you now, contrary to what she reports, might be important when you're looking at the results from her testing. Or somebody reports feeling fine, despite the fact that their affect seems notably depressed. They're not smiling, they don't look at you a lot, they speak slowly, they sigh a lot. You know, those kinds of little clues. Again, this is mood incongruence, and it suggests things maybe about their level of insight. They're not completely in touch with how they're feeling, or maybe the stigma of mental illness. They don't want to report feeling depressed, or maybe they fear being diagnosed as depressed. And so this is important data for the assessment itself, and it can also give you some guidance as to how to treat the person, you know, perhaps be more gentle and reassuring throughout the whole process. Again, affect is the emotional state that the assessor observes. And you remember some of these words. We've got dysphoric, a person who's depressed or irritable or angry, just not feeling good. Or euthymic, which is normal mood. Person seems normal. Euphoric, anxious. You want to talk about the range of affect. Is it normal? Do they look appropriately sad sometimes? And other times they look happy. That would be as opposed to restricted or blunted or flat. So restricted is somewhat restricted and somewhat less than the normal range. Blunted is more than that, even more restricted, I guess. And flat is very, very restricted, so the person really is somewhat expressionless. Again, one of the symptoms you might see with schizophrenia, for example. And the stability of their affect. Are they all over the place, which is referred to as being labile? They go from laughing to crying in a couple of seconds. Or is their mood or is their affect rather relatively stable throughout the interview? And as we said, the congruency, the appropriateness. Does the affect match the mood, and so on. You'll often see in mental status reports that a person was oriented ×3. Again, this goes back to talking about their level of alertness or awareness, really. Orientation for time, for place, and for person. So those are 3 different types of orientation. Does the person have a pretty good idea of what time it is? Do they know where they are? If they don't, that's a whole other ball game. Do they know who they are and who you are? Sometimes a 4th one is added. You'll see oriented ×4. And that includes oriented to situation. I'm here for an exam. Of course, we're talking about differences, big differences in the kinds of clients you'll be interviewing. And if you have someone who's not fully oriented, that might be because you're on a psychiatric ward interviewing a patient there who is in some state of confusion. Okay. Just as it's important to evaluate the person's emotional state, you want to also evaluate both the thought process and the thought content. Thought process, first of all, refers to how a person thinks, the rate of thoughts, how they flow, whether they flow in a goal-directed, logical kind of way, or in a way that suggests some problems in thinking, like tangential or circumstantial or concrete kinds of thinking, and I'm going to define those for you in a minute. In fact, let me define you for them now. Okay. So, first example here. This describes the person's train of thought. And this is a linear thought process. And you'll see that term in the mental status exam, or you will write that term in the mental status exam. Thought process was linear. The person starts on some line of thinking and follows it through in a linear, logical way to the finish or the conclusion. I was home. I felt some chest pain. So I told my son, and he called an ambulance, and now I'm here. Circumstantial thinking. In this case, the person provides some unnecessary detail. Well, you can think of your own example. I won't go there. But they eventually get to the point. They do get back to the point. So circumstantial thinking can be difficult to follow, but it doesn't indicate a serious functional problem, although it might suggest that the person has some difficulties in communication or interpersonal functioning. Again, you want to, when you're evaluating any of this stuff, it's really important that you've evaluated the person's language abilities as well, because remember, this is the way you're going to be able to observe their thought process, basically. So the two things are very much linked. So somebody with circumstantial thinking will eventually get back to the point and answer your question, even if it's in a roundabout kind of order. Oop, let me go back. Okay, get us out of here. Okay, so more serious than circumstantial is tangential thinking. A person with tangential thinking may really have some actual cognitive or thought problems, including maybe psychosis or dementia. It could be attributed to other factors that are less significant, like current emotional distress or a lot of anxiety. So if someone with circumstantial thinking eventually comes back to the point, somebody with tangential thinking goes completely off topic in a kind of a stream of consciousness delivery and maybe never gets back to the main point. So I keep going back. I don't mean to do that. Okay. Or you could have someone whose thought process is loose. This is, a little more serious than circumstantial, maybe more serious than tangential, or about the same. You've got somebody who's shifting around a lot between topics. So the example here would be, I was home, felt some chest pain, hate to ride on the bus, I've always been good at math, I like your shoes. Do you have any children? You get the idea. Finally, concrete thought process. You probably have an idea what concrete thought process is. This is someone who is very literal. They are they don't evidence any real conceptual or abstract kind of thinking. And this can be, this ranges, of course, in degree. So it can be someone who's somewhat concrete, or someone who's so significantly concrete that it suggests that they have some cognitive impairment or some intellectual impairment. Other examples of thought process phenomena that you might observe are these kinds of things. You might describe someone as evincing flight of ideas. So they are probably manic, or very, very excited about something, or maybe they're on crystal meth or something, and they're just quickly moving from one idea to another. So a little bit like what you saw with this sort of loose thinking, They're going from one thing to the next, to the next, and the next. They may finish the idea, but then they quickly go on to something else. Thought blocking, where the person will stop in the middle of something and not be able to complete their thought. Perseveration, someone who continually repeats certain words, certain phrases, certain ideas. This suggests, again, cognitive difficulties or intellectual impairment. It's more likely, it's real characteristic in somebody with this, some kind of frontal lobe injury to the brain. And then word salad, again, you probably remember this as one of the symptoms you see sometimes in schizophrenia. The person just kind of randomly talks, and it doesn't make much sense at all.